Welcome to the Radon Smart Review GU Cancer Series, Episode 26, RCC Planning Workshop Primary and Metastatic SBRT Cases. So, imagine trying to hit an apple with a high-powered rifle.
Okay.
But the apple isn't just sitting on a table. It's suspended on a string.
Uh-huh.
And it's like bouncing up and down maybe 2 or 3 centimeters every few seconds.
Right. And you're trying to track that.
Exactly.
Yeah.
Now imagine that bouncing apple is tightly surrounded by these sheets of incredibly delicate, paper-thin glass that you just absolutely cannot shatter.
Yeah, that's a perfect analogy.
And to make it even more complicated,
Yeah.
you can't obliterate the entire apple. You actually have to leave just enough of its core intact to keep a whole physiological system from failing.
Which is exactly the tension we face, right? I mean, that scenario really captures what it feels like at the console when we're tasked with delivering ablative radiation to the kidney.
Yeah, it's incredibly demanding.
It is, because that tension is really the defining characteristic of this site. Treating the kidney with stereotactic body radiation therapy, or SBRT, is a motion management problem and an organ at risk problem long before it ever becomes a dose problem.
Right, it's not just about picking a number.
No, not at all. The anatomy is volatile, the surrounding structures are highly radiosensitive, and the biological stakes of getting it wrong are just massive.
So what's the mindset going in?
Well, the fundamental board defensible mindset you have to carry into the simulation room is not, I have a preferred dose I want to use. It has to be, I am going to deliver the most ablative regimen that this specific patient's anatomy and organs at risk will safely allow.
Right. Establishing that mindset is critical. But, before we dive into the physics and the biology of how we actually accomplish that, we have to establish the clinical boundary line.
Yeah, we absolutely do.
We have to set the non-negotiable anchor for this whole deep dive, which is that surgery remains the absolute standard of care. It's the curative benchmark for operable localized renal cell carcinoma, or RCC.
Oh, 100%. We have decades of robust data showing exceptional outcomes with partial or radical nephrectomy.
Right, like we are not sitting here having this discussion because radiation has magically replaced the scalpel for a healthy 50-year-old with a localized mass.
Definitely not. The surgical data is literally the foundation of GU oncology. We only start talking about primary kidney SBRT when a patient crosses a very specific threshold.
Like when they're medically inoperable.
Yeah, exactly. They are either medically inoperable due to severe comorbidities, or they present a technically prohibitive surgical risk. Or maybe they have explicitly declined surgery after a really thorough documented multidisciplinary review.
And if you were sitting in a tumor board or facing an examiner and you fail to articulate that surgical standard first,
your entire subsequent plan sounds fundamentally ungrounded. You have to start there.
Context dictates management, always. But when you are faced with that patient who truly cannot survive an operating room, the ability to deliver ablative radiation safely becomes incredibly high yield.
And those are the scenarios that really test your limits in the clinic.
And the ones examiners love to present right. They usually involve a solitary functioning kidney or a mass intimately pressed against the bowel, or a patient whose systemic therapy is working beautifully everywhere except for one rogue escaping metastasis.
Right. So to pull the theoretical physics down into reality, we're going to anchor our session today around 2 highly specific, complex clinical scenarios.
Because the anatomy dictates everything.
Exactly. We have to look at the human being attached to the anatomy because the systemic physiology really dictates the radiation physics.
Okay, let's lay out the parameters for case 1. You are consulting on a 74-year-old man. He has severe chronic obstructive pulmonary disease, or COPD, and he is oxygen dependent at baseline.
Okay, so pulmonary status is extremely poor.
Yeah. We run his renal panels, and his estimated glomerular filtration rate is eGFR is 52. He's already in the territory of chronic kidney disease.
Got it.
A multiphasic CT scan reveals a 4.8 centimeter mid-pole left renal mass. The interventional radiology team performed a core biopsy, and the pathology confirms clear cell RCC. The International Society of Urological Pathology, or ISUP grade, is 2.
And I'm guessing urology evaluated him.
Yeah, the urologic oncology team evaluates him, and primarily due to his severely compromised pulmonary status, they deem him medically inoperable.
Yeah, I mean, the risk of general anesthesia there, specifically the inability to successfully extubate him postoperatively, given his COPD and home oxygen requirement, it just makes the surgical morbidity entirely unacceptable.
So the natural next thought for a non-surgical candidate is thermal ablation.
Right, usually.
But interventional radiology evaluates him and explicitly declines to proceed with cryoablation.
Really? Because of the location.
Exactly, because this 4.8 centimeter mid-pole mass sits directly against the descending colon.
Yeah.
The physics of cryoablation dictate that the lethal ice ball must extend several millimeters beyond the visible tumor margin to ensure cell death.
Oh, wow. Yeah, that's a huge problem.
If they drop the temperature of the adjacent colon wall to minus 40 degrees Celsius, the extreme cold will cause protein denaturation and cell membrane rupture in the bowel wall.
Which is disastrous. Best case scenario, he develops a severe ischemic stricture.
And worst case, the necrotic bowel wall gives way a few days later, creating a catastrophic fecal fistula right into the retroperitoneum.
So surgery is out and thermal ablation is out. That leaves us.
It does.
To complete the workup, we obtain a split renal function study. It shows his renal function is split symmetrically 50-50 between the left and right kidneys.
And the contralateral right kidney is morphologically normal.
Right. His staging scans chest, abdomen, and pelvis show zero evidence of metastatic disease. So we have a localized 4.8 centimeter mass in a medically fragile patient. The question is how we approach this safely.
We will hold that scenario in our minds and lay out case 2, which shifts our focus from the primary setting to the oligometastatic setting.
Okay, let's hear it.
You are evaluating a 65-year-old man with metastatic clear cell RCC. He is currently being managed by medical oncology with the dual immunotherapy combination of ipilimumab and nivolumab.
And how is he doing on that?
He has been on this regimen for 18 months, and his systemic response has been excellent. The drug is working. But his routine restaging CT scan now reveals a single, newly enlarging right adrenal metastasis.
Okay. How big is it?
It currently measures about 3 centimeters. The entire remainder of his disease-burdened lungs, liver, bones remains completely stable or radiographically undetectable.
This is the classic oligoprogressive presentation.
Right.
The clinical question here is whether structural local therapy with SBRT is biologically and technically appropriate for this single progressing site, and how the surrounding anatomy changes our planning approach compared to the primary kidney lesion in case 1.
These 2 cases are just incredibly dense. They force us to navigate the unique challenges of the perirenal and adrenal space.
They do. And to organize our approach to these structures, we rely on a specific cognitive framework. We call it the MOR mnemonic. MOR.
Let's unpack that. The M stands for motion right.
Yeah, exactly. We are dealing with structures that are subject to the continuous rhythmic displacement of the diaphragm. When a patient takes a breath, the diaphragm contracts and pushes downward into the abdominal cavity.
Right.
The kidney and the adrenal gland sitting superior to it are physically forced inferiorly. When the patient exhales, the diaphragm relaxes and the organs slide back superiorly. We are talking about craniocaudal excursions that routinely reach 2 to 3 centimeters.
It's the apple bouncing on the string.
Exactly.
And that movement isn't just a simple linear elevator ride either. The kidney pitches, it rolls, and it compresses slightly against the liver on the right or the spleen on the left. The motion is incredibly complex and volumetric.
Yeah, it's not straightforward at all.
If we treat the kidney as a static object on a single CT snapshot, our ablative dose will miss the tumor entirely during half of the respiratory cycle, and we will instead ablate healthy critical tissue.
Which is why deliberate motion characterization is totally mandatory.
So that's M for motion. What about the O?
The O in the framework stands for organs at risk. The anatomy surrounding the kidney and adrenal glands is incredibly unforgiving. We are operating in a highly crowded, radiosensitive neighborhood.
That's packed in there.
On the right side, you must account for the liver parenchyma, the descending duodenum, and the hepatic flexure of the colon. On the left side, you are managing the stomach, the spleen, the tail of the pancreas, and the descending colon.
These are the delicate glass structures from the analogy.
Precisely. And the biological architecture of these organs is what makes them so dangerous to treat near. The bowel and the duodenum are what we call serial organs.
Think of them like a chain, right?
Yes. If you break just one single link in a chain, the entire chain fails. If we deliver an ablative dose to just one tiny focal spot of the duodenum, the stem cells, in the crypts of Lieberkühn, at that specific location, undergo mitotic catastrophe.
Wow.
The mucosal lining fails to repopulate, leading to an ulcer. The submucosal microvasculature undergoes radiation-induced fibrosis, causing deep ischemia. That one small segment becomes necrotic and perforates.
And it doesn't matter that the other 99% of the bowel receives 0 radiation, right? The patient still has a life-threatening abdominal catastrophe.
Exactly. which is fundamentally different from how a parallel organ works, bringing us to the R in the MOR framework.
Renal preservation.
Right. The kidney is largely a parallel organ, and it's composed of roughly 1 million individual functioning units called nephrons. If you destroy 10% of the nephrons with focal radiation, the remaining 90% can often continue to filter the blood and maintain homeostasis.
But that capacity to compensate depends entirely on the patient's baseline functional reserve.
Yeah, that's the catch.
A patient with 2 healthy kidneys can easily tolerate the functional volume loss of a focal SBRT ablation. But our patient in case 1 already has an eGFR of 52. He has chronic kidney disease?
He does.
If we ablate a large volume of his functioning nephrons, the remaining nephrons are forced to drastically increase their filtration rate to clear the body's metabolic waste.
And that process is called hyperfiltration. The afferent arterioles dilate, increasing the hydrostatic pressure inside the remaining glomeruli.
Which seems okay at first, right?
In the short term, yeah, this keeps the patient's serum creatinine stable. But over the span of months and years, that immense mechanical pressure damages the delicate podocytes and mesangial cells.
Oh, man.
It leads to progressive glomerulosclerosis protein leaking into the urine and an irreversible downward spiral of their eGFR.
So the exact same highly conformal radiation plan that is perfectly safe for a healthy 50-year-old can push our fragile 74-year-old patient permanently onto hemodialysis.
Exactly. Renal preservation is a physiological constraint that we must respect just as strictly as the anatomical constraints of the bowel.
So that's motion organs at risk and renal preservation, the MOR framework.
Right.
Because these 3 factors are so critical, they mandate a very specific workup before a patient ever reaches the simulation scanner. The baseline requirement is a tissue diagnosis. We need a biopsy whenever it is clinically feasible and safe.
And we push for tissue because the differential diagnosis for a renal mass is not exclusively malignant.
Right. What else could it be?
Well, we see benign oncocytomas, which can look remarkably similar to RCC on imaging. We see angiomyolipomas.
So subjecting a patient to the physical risks, the nephron loss, and the potential bowel toxicity of ablative radiation for a completely benign lesion is just an unacceptable outcome.
It is entirely unacceptable. Beyond tissue, you must have comprehensive baseline renal laboratory values and a dedicated split renal function study, especially for patients with a solitary kidney or known CKD.
Like a nuclear medicine scan, right?
Right.
NG3 or DMSA scan.
Yes. A CT scan can tell you the physical size of the kidneys, but it cannot tell you how effectively each kidney is filtering blood.
That makes sense. You might see a massive tumor in the left kidney and assume that kidney is completely non-functional, only to run a MANG-3 scan and discover that the left kidney is actually providing 60% of the patient's overall filtration.
Exactly. And if you don't know the split function, you cannot accurately calculate the physiological risk of your radiation plan.
Finally, we need high-quality, multiphasic cross-sectional imaging, either CT or MRI, to characterize the vascular enhancement patterns of the tumor.
And the case must be framed within a multidisciplinary context involving urology, medical oncology, and radiology.
Absolutely. So with that MOR framework and the workup complete, we have to translate our clinical knowledge into a physical prescription.
We have to choose the appropriate dose and fractionation schedule. We do this by climbing what we call the risk ladder.
The risk ladder, I like that.
We evaluate the tumor size and the surrounding anatomy, and we assign a regimen that balances tumor ablation with tissue tolerance.
Because the radiobiology of RCC is really unique. Historically, RCC was considered a radio-resistant tumor.
It was. In the era of conventional radiation, where we gave small daily 2 gray fractions over several weeks, the tumors barely responded.
Why is that?
The classical linear quadratic model tells us that RCC has a low alpha-beta ratio, meaning its cells have a high capacity to repair the sublethal DNA double-strand breaks caused by standard daily radiation.
So to overcome that resistance, we have to deliver massive ablative doses per fraction.
Exactly. When you deliver something like 26 grays in a single session, you are no longer just causing DNA damage. You trigger an entirely different mechanism of cell death.
Right.
The massive dose causes immediate catastrophic damage to the endothelial cells lining the tumor's microvasculature. It activates the acid sphingomyelinase pathway, flooding the cells with ceramide, which triggers rapid endothelial apoptosis.
So the blood vessels inside the tumor just physically collapse, and the entire tumor undergoes secondary ischemic necrosis.
Yeah. That vascular obliteration is exactly why SBRT is so highly effective for RCC.
So looking at the modern risk ladder, the most aggressive anchor point is the single fraction regimen.
Right. If the tumor is small, generally 4 centimeters or less in maximal diameter. And the anatomy is highly favorable, meaning the tumor is entirely surrounded by normal kidney tissue and sitting far away from the bowel or duodenum. A single fraction of 26 gray is an excellent choice.
It delivers an immense biological effective dose, or BED. It maximizes that vascular endothelial damage, and it is highly convenient for the patient.
But the size of the tumor fundamentally alters the geometry of the plan. As the target volume grows, the amount of normal tissue receiving high doses expands exponentially.
So if the tumor is larger than 4 centimeters, we step down the ladder to a multi-fraction approach.
Yes. The default modern standard for these larger masses is a 3-fraction regimen. A common prescription is 42 gray delivered over 3 fractions, 14 grays per day.
By dividing the dose into 3 sessions, we allow the healthy normal tissues a brief window to repair some of the sublethal damage between treatments.
Exactly, while 14 grays per fraction is still massive enough to overwhelm the tumor's repair mechanisms and drive that severe vascular damage.
But the latter isn't just about size. It is ultimately ruled by the O in our framework.
The organ's at risk. Let's look at our 74-year-old man in case 1. He has a 4.8 centimeter mass.
Right, based purely on the algorithm of size. That is over 4 centimeters, so the default starting point is 3 fractions, 42 grays in 3 fractions.
But the anatomy immediately forces a change in strategy. The mass is sitting directly against the descending colon.
Right.
If we attempt to deliver 42 grays in 3 fractions to that target, the steep dose gradient will invariably overlap with the colon wall.
And the physical tolerance of the bowel to a 3-fraction schedule is incredibly strict.
Very strict. If the dose to the colon exceeds that known threshold, the risk of that catastrophic ulceration and perforation we discussed earlier becomes entirely unacceptable.
You do not simply accept a high risk of bowel perforation because you want the plan to look ablative. When the delicate glass is pressed right up against the apple, you must adapt.
You have to. If the constraints for the colon cannot be met safely with 3 fractions, we take another step down the risk ladder to a 5-fraction regimen.
Okay, so what would that look like?
We might prescribe 40 grays delivered over 5 consecutive treatments, or 8 grays per fraction.
And spreading the dose over 5 fractions significantly increases the normal tissue's ability to tolerate the radiation, vastly reducing the risk of late GI toxicity.
It does. It is a highly effective board-defensible adaptation. Furthermore, because this patient has baseline chronic kidney disease with an eGFR of 52, a 5-fraction schedule provides a gentler biological profile for the remaining functional nephrons we are trying to preserve.
And we aren't just guessing at these thresholds, right? The practice guidelines are built on rigorous prospective data for primary kidney SBRT.
Oh yeah, we have great data. That data shows exceptional local control rates, often exceeding 90% in patients who are not surgical candidates.
And it shows that while renal function does decline, it is a slow, predictable, and usually manageable drop if the plan respects the functional reserve.
But you know, the pooled long-term data also serves as a stark warning. It clearly demonstrates the ghost of severe upper GI toxicity when physicians ignore the anatomical reality.
Wait, really?
Yeah, when providers try to force high doses in few fractions into targets that intimately abut the duodenum or the bowel, the complication rates absolutely spike. The latter exists to protect the patient from our own desire to push the dose. You never force a short, condensed regimen just because it sounds more aggressive.
Okay, so the theory is solid. We understand the dose ladder. But having the right theoretical prescription is pretty useless if we cannot execute it physically.
Very true.
Let's walk into the technical workshop and discuss simulation and treatment planning. We are simulating the patient from case 1. He has severe COPD, and he is on home oxygen. How are we managing the MOR framework's first requirement motion?
Well, robust motion characterization is the bedrock of the entire plan. Ideally, for a healthy patient, we might utilize deep inspiration breath hold, or DIBH.
How does that work?
We monitor their breathing, and when they take a deep breath in, they hold it. The diaphragm pushes the kidney down into a stable, highly reproducible position. We turn the beam on while they hold their breath, and we turn it off when they exhale. It effectively freezes the target in space.
But for our case 1 patient with severe COPD, DIVH is a setup for failure.
Total failure. Asking him to predictably and stably hold a deep breath for 20 or 30 seconds is impossible. He will cough, he will gasp, and his diaphragm position will be wildly inconsistent from one breath to the next.
And if you try to treat him during an unstable breath hold, you will miss the tumor and hit the colon.
Precisely. So we have to adapt to his physiology. We will utilize a free-breathing four-dimensional CT, a 4D CT, to map the entire motion envelope.
Okay, so what does that look like in the clinic?
We place a respiratory tracking device like a pneumatic bellows belt around his abdomen. As the CT scanner acquires images, the bellows record the exact phase of his breathing cycle. The software then sorts or bins all of those images into distinct respiratory phases, from peak inspiration all the way to peak expiration.
So we can sit at the planning station and literally watch a movie of his kidney moving through time.
Exactly. We can clearly see the highest point the tumor reaches, the lowest point it reaches, and how it deforms against the surrounding tissues. We are defining the absolute limits of the bouncing apple.
And I imagine the specific treatment machine you use matters somewhat.
Actually, it is essential to emphasize that the specific treatment machine you use matters far less than the rigor of your motion management. Yeah. Whether you are treating on a standard linear accelerator using volumetric modulated arc therapy or VMAT, where the machine dynamically shapes the beam as it rotates continuously around the patient, or if you are using a robotic system like CyberKnife, or an MR-guided linear accelerator that tracks the tumor visually in real time.
The platform is secondary.
Absolutely. The absolute priority is the honesty of your motion strategy and the quality of your daily soft tissue image guidance.
Okay, so once we have that 4D CT dataset, we have to meticulously define our target volumes. We start by contouring the gross tumor volume, the GTV.
Right. This is the visible enhancing mass on the scan. It is the physical tumor itself.
But because we're using a free-breathing strategy for this COPD patient, the GTV is not sitting still.
No, it's not. So we contour the GTV on every single phase of the 4D CT. We then merge all of those contours together to create the internal target volume, the ITV.
The full motion envelope.
Exactly. The ITV represents the entire three-dimensional space that the tumor occupies at any point during the patient's normal breathing cycle.
And from there, we add our final expansion to create the planning target volume, or PTV.
Yes. The PTV is a safety margin. It accounts for microscopic daily setup errors, the mechanical tolerances of the treatment machine, and slight variations in the patient's positioning on the table.
For a robustly immobilized kidney treated with daily soft tissue image guidance, the PTV margin is typically tight, around 3 to 5 millimeters.
Right. And this brings us to a critical rule of primary RCC planning. It is a concept that really distinguishes the deep biological understanding of RCC from other common malignancies like prostate or head and neck cancer.
Well, what is it?
There is absolutely no elective nodal volume included in a primary RCC SBRT plan.
Wow, that is a massive paradigm shift. In prostate cancer, we routinely radiate the pelvic lymph nodes prophylactically because the disease has a high propensity for microscopic lymphatic spread.
Exactly, but clear cell RCC behaves fundamentally differently. It spreads primarily through the hematogenous route invading the renal vein and the inferior vena cava.
Microscopic lymphatic spread to the regional hular or periaortic lymph nodes is much less common in early-stage disease.
And prophylactic irradiation of those nodes has never been shown to improve survival.
And physically, if you attempt to include an elective periaortic nodal strip in your SBRT plan, you destroy the entire physical premise of the treatment right.
You totally do. Your target volume becomes massive. You will encompass vastly more functioning renal parenchyma, large segments of the duodenum, and extensive loops of small bowel.
The dose constraints of those surrounding organs will force you to drastically lower your prescription dose.
Yes, you will trade an ablative curative dose to the primary tumor for a biologically useless low dose to a massive area. The rule is simple and absolute. The target is the visible tumor and its motion envelope, period. We are a sniper, not a shotgun.
I love that. We are a sniper, not a shotgun. So as we finalize the plan, we evaluate our dose volume histograms. We are looking at the bowel, the stomach, the duodenum, the spinal cord, and the remaining healthy renal cortex.
And I want to highlight a crucial aspect of mature planning judgment here, particularly concerning the R in our framework renal preservation.
Right.
The interface between the tumor and the healthy kidney is by far the most difficult area to plan. If a patient has a solitary kidney, or in the case of our patient with an EGFR of 52, every single nephron is vital.
When you look at the dose distribution, the high-dose ablative line might cover 98% of the PTV perfectly. But to get that last 2% of coverage on the medial edge, The physics of the beam might force a massive dose spilled deep into the healthy renal cortex.
Right. And in that highly specific scenario, an experienced radiation oncologist will make a calculated compromise.
Like what?
We might intentionally allow the PTV coverage to drop slightly on that inner edge. We let the dose fall off faster to spare a larger volume of healthy nephrons.
So we accept a microscopic risk of marginal tumor recurrence to completely avoid the absolute certainty of plunging the patient into end-stage renal disease.
Exactly. That is not a failure of planning. That is the sophisticated application of clinical judgment over algorithmic perfection. You never recklessly violate a critical renal or upper GI constraint simply to make a target coverage metric look prettier on a screen.
It is the essence of treating the patient, not the scan.
Exactly.
So to cleanly summarize the resolution for case 1, we have a 74-year-old medically inoperable patient with a 4.8 centimeter clear cell RCC intimately abutting the descending colon. The plan is a multi-fraction regimen.
Right.
While a 3-fraction approach is the standard starting point for a mass of this size, the strict dose limits of the adjacent colon dictate safety. I will evaluate the plan at 3 fractions, but if the colon receives a dangerous dose, I will seamlessly transition to a 5-fraction schedule to protect the delicate glass of the bowel while maximizing renal preservation. I will not force a condensed regimen that the anatomy does not support.
And that is exactly how you articulate a safe, board-defensible plan. We've mastered the primary setting. Now let's pivot to case 2, because this scenario takes the exact same physical and biological OAR logic and applies it to a completely different systemic environment.
Okay, let's do it. We have our 65-year-old man. He has metastatic disease, but he has been on the immunotherapy combination of ipilimumab and nivolumab for 18 months. His systemic response is fantastic, but his recent scan shows a single 3-centimeter right adrenal metastasis that is clearly growing.
Right.
Let's unpack the deep biology of this situation before we talk about radiation. What is actually happening at the cellular level here?
This is the fascinating phenomenon of oligoprogression. When a patient is given systemic immunotherapy, we are trying to activate their own immune system to recognize and destroy the cancer cells. Ipilimumab works in the lymph nodes, blocking the CTLA-4 receptor to allow T cells to become primed and activated against tumor antigens. Nivolumab works directly in the tumor microenvironment, blocking the PD-1 receptor to prevent the tumor from putting the activated T cells to sleep.
And for 18 months, that dual blockade has worked perfectly. The immune system is actively surveilling the body, recognizing the RCC cells, and inducing apoptosis. It is successfully suppressing 99% of the metastatic disease burden.
But cancer is not a monolithic entity. It is a highly heterogeneous population of cells constantly undergoing genetic mutation and clonal evolution.
Right.
Deep within the right adrenal gland, a specific subpopulation of tumor cells has mutated. Perhaps they have downregulated their major histocompatibility complex or MHC proteins, making them invisible to the T cells. Or perhaps they have upregulated entirely different immunosuppressive pathways.
Whatever the specific mechanism, this one clone has found a sanctuary and is actively escaping immune surveillance.
Exactly. And if we do nothing, that resistant clone will continue to grow. It will eventually seed new, entirely immunotherapy-resistant metastases throughout the body, and it will be fatal.
The traditional medical oncology response to progression is to assume the drug has failed completely right. They would stop the ipilimumab and nivolumab and switch the patient to a second-line targeted therapy like a tyrosine kinase inhibitor.
Right. But switching systemic therapies is a massive clinical sacrifice. Second-line drugs often come with a significantly harsher toxicity profile, severe fatigue, hypertension, hand-foot syndrome, and historically they offer lower durable response rates than the initial immunotherapy.
So as radiation oncologists, we step into the multidisciplinary space to solve a focal structural problem, to save a systemic strategy.
The clinical strategy here is profound yet elegant. SBRT is highly appropriate to achieve immediate local control of this one escaping mutated clone.
We physically destroy the resistant cells with ablative radiation.
Yes. By eliminating the rogue site, we explicitly prolong the clinical utility and the benefit of the current well-tolerated systemic regimen. We keep the working drug working for the 99% of the disease it is still effectively managing.
I want to pause and raise a massive caution flag regarding how we communicate this strategy, though. It is incredibly tempting when explaining this to a patient or discussing it in a tumor board to overclaim the biological effects of the radiation. You must not promise magical immunologic synergy.
Yeah, that trap is pervasive. You will hear people talk about the abscopal effect. The theory is that by blasting the adrenal metastasis with radiation, we cause massive tumor cell death, releasing a flood of new antigens into the bloodstream.
Right. The hope is that this antigen release acts like an in situ vaccine, hyperactivating the immune system and causing it to suddenly attack tumors all over the body.
But the abscopal effect is undeniably real in murine models and laboratory settings, and it is endlessly fascinating. But in the reality of human clinical practice, it is statistically incredibly rare.
The tumor microenvironment is fiercely immunosuppressive. Do not frame this treatment by telling the patient that the radiation is going to magically supercharge their ipilimumab and cure their widespread disease.
That kind of overpromising sets up catastrophic disappointment. You must keep your rationale entirely grounded in structural reality. We are using focal therapy to eliminate a focal progression. It is a local solution to a localized clonal escape, coordinated precisely with medical oncology to optimize the sequencing of the drugs and the radiation.
And technically speaking, delivering ablative radiation to the adrenal gland is an absolute nightmare. The adrenal gland is not just a tiny kidney. The anatomical constraints are arguably far more treacherous than the primary perirenal space.
Oh, particularly on the right side. The right adrenal gland is tucked high up in the retroperitoneum. It is bordered superiorly and laterally by the liver, anteriorly by the inferior vena cava, and most dangerously, it sits in extremely close proximity to the descending duodenum and the posterior stomach.
The terrifying reality of adrenal SBRT is the volatility of the upper gastrointestinal tract. You can craft a plan that looks flawless on the day of simulation. The patient's stomach is perfectly empty, and the duodenum is resting a comfortable 2 centimeters away from your high-dose ablative target volume. The dose volume histograms are spectacular.
But the stomach and the bowel are highly dynamic structures. On day 2 of the actual treatment, the patient might have eaten a heavy breakfast, or they might have increased intestinal gas. The stomach violently distends and the duodenum shifts posteriorly.
Suddenly, that delicate glass we talked about is resting directly inside your target volume.
Exactly. If you turn the beam on without knowing that the anatomy has changed, you will deliver an ablative dose directly into the mucosal wall of the stomach, guaranteeing a severe ulceration or perforation.
This is where image-guided radiation therapy, or IGRT, becomes a matter of life and death. We don't just rely on lasers and skin marks.
No, we acquire a cone beam CT scan, a 3D volumetric image, while the patient is on the treatment table mere minutes before we initiate the radiation. We carefully evaluate the soft tissue.
We aren't just checking if the adrenal tumor is in the crosshairs. We are actively interrogating the surrounding structures. Has the stomach expanded? Has the bowel migrated into the danger zone?
And if the bowel is shifted into the high-dose region, the treatment stops. You take the patient off the table, you give them a glass of water to change the gastric volume, or you have them walk around, or you simply send them home and try again the next day.
You do not ever deliver the dose until the daily anatomical reality matches the safe conditions established in your simulation plan.
Exactly. That extreme volatility is exactly why adrenal SBRT is rarely pushed into a single fraction regimen. The risk of catastrophic misjudgment on any single day is just too high.
Fractionating the treatment over 3 to 5 sessions allows us to average out the daily anatomical variations and provides a much wider safety margin for the upper GI tract.
You let the constraints of the stomach, the duodenum, the bowel, the liver, the spinal cord, and the ipsilateral kidney drive the regimen.
So to cleanly summarize case 2 for clinical presentation, this is a patient with oligoprogressive metastatic RCC demonstrating a focal clonal escape while on an otherwise highly effective systemic immunotherapy regimen.
Right.
SBRT, to the progressing right adrenal metastasis, is a biologically and technically sound local therapy designed explicitly to prolong the utility of his current systemic drugs. I will coordinate the sequencing carefully with his medical oncologist, and I will plan the case with obsessive attention to upper abdominal OAR constraints, utilizing a 3 to 5 fraction schedule guided by rigorous daily volumetric imaging.
That's a perfect summary.
So the plans are approved, the physics checks are complete, the patient goes through the 3 or 5 days of treatment. Now we enter the post-treatment phase. The radiation has been delivered, but from a biological standpoint, the violence inside that tissue is only just beginning. How do we actually sit across from these patients in the clinic and prepare them for what happens next?
Patient counseling requires maturity, precision, and a deep understanding of the delayed biological effects of SBRT. You have to balance the high efficacy of the treatment with the unalterable anatomical realities.
What's your approach?
My phrasing is very deliberate. I tell them kidney SBRT offers a very high chance of permanently controlling your tumor. However, the mandatory physiological trade-off for that control is a measurable permanent decline in your overall kidney function.
Yeah, that's honest.
Furthermore, because of how closely your tumor rests against your bowel, there is a small but very real risk of severe upper GI injury in the future, which could present as bleeding ulceration or, in extreme cases, a bowel perforation.
I deeply appreciate that phrasing. You completely avoid the pervasive trap of reassuring the patient that the treatment is quote-unquote easy or has minimal toxicity just because it's not invasive. Yeah. When you deliver 42 grays in 3 fractions, there is absolutely nothing minimal about the cellular destruction occurring inside their body.
It is vital to separate acute toxicity from late toxicity in their minds. Acutely meaning during the week of treatment and the first few weeks following the therapy is remarkably well tolerated. SBRT doesn't cause the systemic sickness associated with chemotherapy.
They will likely experience some fatigue, right?
Yes. If the radiation field is near the stomach or duodenum, they might experience mild transient nausea, which we manage easily with antiemetics. They occasionally report a dull transient ache in their flank as the inflammatory cascade begins. We monitor their blood work, and we often see a modest temporary elevation in their serum creatinine as the kidney tissue reacts to the initial stress.
But the acute phase is just the prologue. The late toxicity, the physiological changes that manifest 6 months, a year, or even 2 years down the line, that is where the profound, unalterable effects of our treatment live.
The defining late toxicity is the permanent decline in renal function. The nephrons within the high-dose volume are dead. They will not regenerate. That functional loss is the unavoidable reality of ablating a target inside a parallel organ.
As the surviving nephrons attempt to compensate through hyperfiltration, the overall eGFR slowly drifts downward.
And the other paramount late toxicity is that rare but catastrophic upper GI injury. If a practitioner pushed the dose too aggressively near the duodenum, the slow progression of submucosal fibrosis and ischemia can silently weaken the bowel wall.
Right. 6 to 12 months later, that patient can present acutely to the emergency department with a massive upper GI bleed or a full-thickness bowel perforation requiring emergency surgery.
That delayed reality is precisely why we are so uncompromising about adhering to the risk ladder and respecting the OAR constraints during planning.
The late biological effects also dictate exactly what happens when the patient returns for their first follow-up CT scan 3 months later. I call this the messy radiograph trap.
Oh yeah, that's a great name for it.
A resident or a junior attending pulls up that first post-SBRT scan, they compare it to the baseline, and they instantly panic. Let's explain the physics of why irradiated kidneys look so incredibly confusing on imaging.
It comes down to the mechanism of tissue destruction. When a surgeon performs a partial nephrectomy, the tumor is physically removed. The first post-op scan shows a clean surgical defect. The mass is simply gone.
And when interventional radiology performs a thermal ablation, the extreme heat or cold instantly liquefies the cells. The first scan shows a distinct non-enhancing hole in the tissue.
But radiation does not evaporate matter. As we discussed, SBRT induces catastrophic DNA double-strand breaks and massive vascular endothelial damage. The tumor cells don't vanish. They die a slow, agonizing death.
The microvasculature collapses, leading to deep ischemic necrosis.
That process takes months and sometimes years to fully resolve. The tissue undergoes a massive chaotic inflammatory response. Macrophages infiltrate the area to clear the necrotic debris. The surrounding tissue becomes hyperemic, meaning there is increased blood flow due to the inflammation.
Deep within the tumor, fibrotic changes begin to replace the cellular architecture, leaving a dense, non-functioning scar.
Because of that intense inflammatory cascade and the resulting edema, the physical mass of the tumor might actually appear larger on that very first follow-up scan at 3 or 4 months.
Furthermore, the chaotic neovascularization and the disrupted blood-brain barrier equivalent in the kidney can cause highly abnormal contrast enhancement kinetics. The mass might retain contrast, weirdly simulating viable tumor.
This is the clinical pearl that every radiation oncologist must internalize. Do not panic. Do not look at a post-SBRT CT scan and expect it to look like a clean surgical bed. Most importantly, do not overcall a local treatment failure based on one single imperfect early scan.
The radiographic response is inherently messy. The standard of care is active patient surveillance. We establish a regular rhythm of cross-sectional abdominal imaging, typically a high-quality multiphasic CT or MRI, that fully evaluates the kidneys and the adrenals, alongside routine chest imaging and renal function labs.
We usually perform these every 3 to 6 months. We are not reacting to a single snapshot. We are looking for a definitive trend over time.
We evaluate the evolution of the mass. Does the solid enhancement pattern slowly fade? Does the overall volume of the mass gradually shrink or stabilize over the course of 12 to 18 months? Does a central area of non-enhancing necrosis develop and expand?
And a common reflex when a scan looks confusing is to suggest sticking a needle in it.
Right. If the mass looks slightly larger at 3 months, why don't we just perform a biopsy to see if the radiation worked?
Because a biopsy in that setting is practically useless and potentially harmful. Routine post-treatment biopsy is never the default response assessment strategy. If you biopsy a heavily irradiated kidney mass at 3 or 6 months, the pathologist is going to look under the microscope and see cells. Those cells might look highly bizarre. They might be in the active process of dying. They might be entirely incapable of ever dividing again, but physically they are still present.
It is incredibly difficult, even for an expert genitourinary pathologist, to definitively differentiate between profound radiation-induced atypia and genuinely viable proliferating tumor cells.
You only consider the risks of a post-treatment biopsy if the imaging trend consistently and unequivocally demonstrates solid tumor growth across multiple sequential scans over a period of many months, or if the patient's clinical presentation strongly raises a high suspicion for true aggressive local progression.
In the post-SBRT setting, active discipline patients is not just waiting, it is a deliberate clinical strategy.
We have journeyed from the surgical fundamentals through the biological MOR framework, deep into the physics of treatment planning, and out into the complex reality of post-treatment biology. It's time to synthesize this knowledge.
Let's run a rapid-fire review to cement these core concepts. This is the board blitz. I will present a highly specific clinical scenario, and you give me the precise board-clean reaction. Are you ready?
Let's do it.
Question 1. You are evaluating a patient who is medically inoperable due to severe cardiac disease. They have a 5.5 centimeter biopsy-proven clear cell RCC. The mass is located on the lower pole of the right kidney and intimately abuts the descending duodenum. What is your fundamental planning mindset and strategy for this case?
My overarching mindset is to prioritize the safety of the duodenum above all else. Because the tumor is over 4 centimeters, my initial thought leans toward a multifraction strategy starting with 3 fractions. However, I will strictly let the specific OAR constraints of the duodenum dictate the reality of the plan. If the 3-fraction constraints cannot be safely met without risking severe upper GI toxicity, I will expand the regimen to a 5-fraction schedule to protect the gut while still delivering an effective ablative dose.
An excellent, safe approach. Question 2. You successfully treated a patient with SBRT for a primary RCC 6 months ago. Their very first follow-up CT scan shows that the treated renal mass is actually slightly larger in maximum diameter today than it was on the baseline planning scan. What is your immediate clinical action?
My immediate action is observation. I will not reflexively label this a local failure. I understand that radiation induces massive inflammation in INA and a slow necrotic process that can temporarily increase the radiographic volume. I will correlate the size with the timing of the scan, evaluate the contrast enhancement characteristics, and wait for subsequent follow-up imaging to establish a definitive long-term trend before ever considering salvage surgery or a high-risk biopsy.
Restraint is key. Final question. A patient with widely metastatic clear cell RCC has been on an effective dual immunotherapy regimen for over a year. Their disease burden is stable across all organ systems except they have developed one single newly enlarging metastasis in the right adrenal gland. What is the clean, strategic, biological, and clinical plan?
This represents oligoprogression, a focal clonal escape. SBRT directed to the right adrenal gland is a highly appropriate local therapy. The biological goal is to achieve local control of this one resistant site, thereby explicitly prolonging the clinical benefit of the current systemic immunotherapy regimen for the rest of his disease. I would coordinate the sequencing directly with medical oncology and execute the plan with obsessive attention to the shifting upper abdominal OARs, heavily relying on daily volumetric image guidance to protect the stomach and bowel.
That brings it all together beautifully. The through line here is undeniable. Whether we are dealing with a primary mass the size of a golf ball resting dangerously against the colon, or a tiny mutated adrenal metastasis hiding behind the duodenum, the radiation oncologist's fundamental job is to safely navigate the treacherous physics of upper abdominal anatomy.
And that brings us to the ultimate unifying takeaway of this entire session, the core philosophy that governs the pararenal space. If you remember only one phrase from the thousands of words we've shared today, let it be this: do not start with the dose. Start with the anatomy.
Start with the anatomy. I want to leave you with one final thought to mull over before we close. We spent significant time discussing SBRT for oligoprogression as a structural method to control an escaping site and salvage the systemic therapy. But think deeply about the localized microenvironment of that treated kidney or adrenal gland in the months after the radiation. We know we are causing massive endothelial damage and generating dense fibrosis. As you go back to your clinic, ask yourself, are we merely creating a physical fibrotic scar that traps the dying tumor, or is that massive dose of radiation fundamentally altering the local immune landscape? Could the destruction of the microvasculature and the influx of macrophages be priming resident immune cells in ways we are only just beginning to understand, completely independent of the abscopal myth? It's a profound question that bridges the gap between the structural plumbing we execute at the console and the vast uncharted biology of the immune system. Complete practice oral boards at redonsmartlearn.com and subscribe to Red on Smart Review for our next episode. Thanks for tuning in.